Welcome students. Today we are going to see about the management of kidney failure, mainly the hemodialysis and the peritoneal dialysis. The main function of the kidney is to maintain the homeostatic balance with respect to fluids, electrolytes and organic solutes. The normal kidney can perform this function over a wide range of dietary fluctuations in sodium, water and various solutes. The manifestation of renal disease are direct consequences of the portions of the urinary tract systems that are affected. These manifestations include glomerular diseases, acute renal failure, tubular defects, end-stage renal disease and renal stones. Objectives of nutritional care depends on the abnormality that is being treated. Chronic kidney disease involves progressive irreversible loss of kidney function. The Kidney Disease Outcomes Quality Initiative of the Kidney Foundation defines chronic kidney disease as either the presence of kidney damage or decreased glomerular filtration rate less than 60 ml per minute per 1.73 meter square for longer than 3 months. The chronic kidney disease result from gradual progressive loss of renal function and occasionally result from rapid progression of acute renal failure. The symptoms occur when 75% of function is lost but considered chronic if 90 to 95% loss of function. The stages of chronic renal failure includes as follows. Stage 1. Here the kidney damage with normal or increased GFR. The glomerular filtration rate will be less than or equal to 90 ml per minute per 1.73 meter square. The clinical action plan is to diagnose and treatment, the CVD risk reduction and slow progression. In stage 2, the kidney damage will be mildly decreased and the GFR of 60 to 89 ml per minute, and the clinical action plan is to estimate the progression. In stage 3, the kidney damage with moderately decreased GFR of 30 to 59 ml per minute, and the clinical action plan is to evaluate and treat the complications. In stage 4, the kidney damage with severely decreased GFR of 15 to 29 ml per minute, and the clinical action plan is preparing the kidney for the replacement therapy. And in stage 5, complete kidney failure with decreased glomerular filtration rate of less than 15 ml per minute, and the clinical action plan is to replace the kidney if uremia is present and the patient desires treatment as well. Moving on to the causes of chronic kidney disease. Systemic disease such as diabetes, hypertension, chronic glomerulonephritis, pyelonephritis, obstruction of the urinary tract, hereditary lesions as in polycystic kidney disease, vascular disorders, infections, medications or toxic agents. The symptoms of chronic kidney disease include psychologic, which includes the anxiety and depression, and neurological, which includes fatigue, headache, sleep disturbances and encephalopathy. And with relevant to cardiovascular, there is chances of hypertension, heart failure, coronary artery disease and peripheral artery disease. With relevance to gastrointestinal, there seems to be anorexia, nausea, vomiting, gastrointestinal bleeding and gastritis. And chances of ocular hypertensive retinopathy, there is pulmonary edema, uremic phleuritis and pneumonia. With related to endocrine, there are chances of hyperthyroidism, thyroid abnormalities, amenorrhea, erectile dysfunction, and integumentary, there is a chance of pruritus, echinosiosis, dry and scaly skin, and there is metabolic carbohydrate intolerance, hyperlipidemia, and with relevant to hematologic, there are chances of anemia, bleeding and infection, and there are chances for peripheral nephropathy, and seems there is chance of paresthesia, restlessness, leg syndrome. There is chance of musculoskeletal, vascular and soft tissue calcification and osteomalacia. And the diagnosis involves as follows: history and physical examination, identification of reversible renal disease, renal ultrasound, CT scan and renal biopsy. With relevant to blood urea nitrogen, which is an indicator of glomerular filtration rate and is affected by the breakdown of protein. Normal is 10 to 20 milligram per dl. When reaches 70, dialysis must be. And with relevant to serum creatinine, the waste product, which is a waste product of skeletal muscle breakdown and is a better indicator of kidney function. The normal level is 0.5 to 1.5 milligram per deciliter. When reaches 10 or more than the normal, and the chances of dialysis. Creatinine clearance is the best determinant of kidney function, and it must be a 12 to 24 hour urine collection, and the normal is more than 100 ml per minute. Moving on to dialysis, which is the best management for kidney disease. Dialysis is the movement of fluid and molecules across the semi-permeable membrane from one compartment to another. Clinical dialysis is a technique in which substances move from blood through the semi-permeable membrane and into a dialysis solution, which is called dialysate. Dialysis can be accomplished either by hemodialysis or by peritoneal dialysis. The most common method is hemodialysis, in which the blood passes by the semi-permeable membrane of the artificial kidney and the waste products are removed by diffusion and the fluids by ultrafiltration. Let's look upon in detail on hemodialysis. Hemodialysis requires permanent access to the bloodstream through a fistula created by surgery to connect an artery and a vein. Fistulas are often made near the wrist, which greatly enlarges the forearm veins. If the patient's blood vessels are fragile, an artificial vessel can be which is called as a graft, may be surgically implanted. Large needles are inserted into the fistula or graft before each dialysis and removed when dialysis is complete. Temporary access through subclavian catheters is common until the patient's permanent access can be created and can mature. However, infection problems make these catheters much less desirable. The plastic tubing attached to the needles connect the patient to the artificial kidney. The artificial kidney contains two compartments, one for the patient's blood and one for cleaning solution called the dialysate. A thin porous membrane separates these compartments because they are large to pass through, while smaller waste products like urea and creatinine in the blood and excess water passes through the holes of the membrane and are washed away. The clean blood now enters the patient's body. Needed substances like calcium or dextrose can be added to dialysate. The dialysis fluid electrolyte content is similar to that of normal protein. Waste products and electrolytes move by diffusion, ultrafiltration and osmosis from the blood into the dialysate and they are removed. Hemodialysis usually requires treatment of 3 to 5 hours 3 times per week. The dietary protein needs are about 1.2 gram per kg body weight. About 50% high biological value protein to make up the loss through the dialysate must be supplied. The blood flow rates of 200 to 300 ml per minute are usual. Heparin is given intermittently or infused continuously to prevent clotting of blood in the dialyzer during 3 to 6 hours procedure. Adequate clearances can usually achieve by a total 12 hours of hemodialysis per week on a thrice weekly schedule. For hemodialysis and patients unable to take oral supplements, interdialytic parenteral nutrition is a means of providing adequate calories and proteins. Now moving on to peritoneal dialysis. Peritoneal dialysis makes use of the semi-permeable membrane of the peritoneum. A catheter is surgically implanted in the abdomen and into the peritoneal cavity. Dialysate containing a high dextrose concentration is instilled into the peritoneum, where diffusion carries waste products from the blood through the peritoneal membrane and into the dialysate. Water moves by osmosis. This fluid is then withdrawn and discarded and new solution is added. Several types of peritoneal dialysis exist. Standard peritoneal dialysis is a less efficient method of removing the waste products from the blood. Treatments usually last longer than hemodialysis, about 10 to 12 hours per day, 3 times per week. This type of treatment is rarely done anymore. Patients with peritoneal dialysis have higher protein needs because of greater protein loss. The other type, the continuous ambulatory peritoneal dialysis, is similar to the standard peritoneal dialysis, except that the dialysate is left in the peritoneum and exchanged manually so that no machine is required. Exchanges of dialysis fluid are done 4 to 5 times daily, making it a 24-hour treatment. The protein losses are somewhat higher than those of regular peritoneal dialysis. Advantages of this form of treatment are avoidance of large fluctuations in blood chemistry and the ability of the patient to achieve a more normal lifestyle. Patient with continuous ambulatory peritoneal dialysis have more liberal fluid, sodium and potassium allowances because the therapy is continuous and more of these products are removed. The loss of sodium can be as much as 6 grams per day, thus these patients may need higher sodium intakes. Complications associated with continuous ambulatory peritoneal dialysis include peritonitis, hypotension that require additional fluid and sodium replacement, and weight gain. The weight gain is experienced by most patients with continuous ambulatory peritoneal dialysis as a result of absorbing 600 to 800 calories per day from the glucose in the dialysate. This may be desirable in patients who are underweight, but eventually dietary intake will have to be modified to dialysate. Another type of peritoneal dialysis is continuous cyclic peritoneal dialysis, CCPD. In this therapy, which is somewhat the opposite of CAPD, the patient's treatments are done at night by a machine that does the exchanges. During the day, these patients may keep a single dialysate exchange in the peritoneal cavity for extended period of time, perhaps the entire day. Several combinations of CAPD and CCPD, which is continuous ambulatory peritoneal dialysis and continuous peritoneal dialysis, are possible. The characteristics of dialysis, mainly let's look upon the hemodialysis. This takes only 3 to 5 hours per treatment, requires only 3 treatments weekly, requires surgical creation of vascular access between circulation and dialysis machine, requires complex water treatment, expensive dialysis equipment and highly trained personnel, require large doses of heparin, confines patient to special treatment unit, risk of complication is more. With relevant to peritoneal dialysis, this could be performed immediately, requires a less complex equipment and less specialized personnel. It can be performed by patient anywhere without assistance, requires small amount of heparin or nothing, allows patient independence without long interruption in daily activities, allows for more liberal diet, and it costs less. Oral iron is given because there is a chronic small loss of blood that cannot be returned to the patient at the end of each dialysis. The major cause of anemia appears to be lack of erythropoietin together with the depression of erythropoiesis by azotemia or uremia. Vitamin supplementation is prescribed for renal failure patients, including dialysis patients, because restricted diets, uremic toxins, and affects the process of dialysis increase the risk of clinical and subclinical vitamin deficiency. For hemodialysis patients unable to take oral supplements, interdialytic parenteral nutrition is a means of providing adequate calories and proteins. Correction of anemia is done by using erythropoietin, supplementation of iron, folic acid, B12 and vitamin C, and improves the overall well-being and appetite of the patient. Vitamin B6 may be given at the rate of 80 to 160 mg per week. Dialysis contributes to loss of ascorbic acid and folic acid. During dialysis, the requirements for B complex and vitamin C increase while the requirement for vitamin A and D decrease. In malnourished patients, supplementation of carnitine helps to improve the general well-being. A rise in serum creatinine to 2.4 mg per dl produces a 25% fall in the normal level of serum bicarbonate. This should be corrected by giving oral alkali such as sodium bicarbonate or sodium citrate to increase the bicarbonate level to 20 to 23 milliequivalent per dl. Hyperlipidemia may manifest when the glomerular filtration rate falls to 15 to 30 ml per minute. Dietary manipulation and drug therapy may help prevent atherosclerosis complication. However, there are some limitations for dialysis. Now, let's move on to the nutritional therapy and dietary management of dialysis. Patients on hemodialysis lose about 8 to 9 grams of amino acids along with 2 to 3 grams of peptides during each session, leading to a net loss of 10 to 13 grams per dialysis. The energy requirement of a hemodialysis patient is about 35 kilocalories per kg body weight, and protein requirement is 1.1 gram per kg for continuous ambulatory peritoneal dialysis and CCPD. The protein requirement is 1.3 gram per kg body weight. Dietary salt, potassium, phosphorus and water intake should be restricted to, and salt 3 to 4 gram, potassium 50 to 70 milliequivalent per day, phosphorus 1 gram per day, and water according to the urine output of the patient. Vitamin A increase in dialysis patient and supplementation is not recommended. Patients approaching the end-stage renal disease but not yet initiated on hemodialysis should consume protein at the rate of 0.6 gram per kg body weight. If protein is restricted to a lower level, the diet should be supplemented with keto analogues of essential amino acids to prevent malnutrition. Patients on chronic hemodialysis usually require a slightly reduced protein intake, but more stringent control of salt and potassium intake is needed to maintain the satisfactory levels of blood urea nitrogen, potassium and blood pressure. And to be avoided are the cured meats, pickled foods, canned soups and stews, cold cuts, soy sauce, preserves and salad dressings. Potassium restrictions about 2 to 3 grams. And to avoid orange, bananas, melons, tomatoes, prunes, raisins, deep red and yellow vegetables, beans and legumes as well. Phosphate restriction is limited approximately to 1 gram per day. Avoid milk products and meat products. The fluid allowance is 500 to 600 ml more than the previous day's 24-hour urine output. Calories are supplied by carbohydrates and fat to prevent wasting. Here comes the daily recommendations for patient with chronic kidney disease. Moving on to foods to be avoided. The high sodium foods to be avoided for the dialysis patients includes as follows. High sodium foods such as bread, grains and cereals, the bread and rolls with salted tops, quick bread, self-rising flour, biscuit, pancake and waffle mixture, pizza, croutons and salted crackers, pre-packaged processed mixes for potatoes, rice, pasta and stuffings, etc. And among the vegetables and fruits, regular canned vegetables and vegetable juices, olives, pickles, sauerkraut and other pickled vegetables, vegetables made with ham, bacon and salted pork, packaged mixes, frozen hash browns and tater tots, commercially prepared pasta and tomato sauces and salsa. With relevant to dairy products, buttermilk, regular and processed cheese, cheese spreads and sauces and cottage cheese. With related to meat, poultry, fish, legume, eggs and nuts, smoked, cured, salted or canned meat, fish or poultry including bacon, cold cuts, ham, frankfurter, sausage, sardine, caviars and anchovies, frozen breaded meats, salted nuts, pizzas, beans canned with salt added. With relevance to fat, dessert and sweets, soy sauce, seasoning, salt, other sauces and marinades, bottled salad dressings, regular salad dressings with bacon bits, salted butter or margarine, instant pudding and cake, large portion of ketchup and mustard. With relevant to high potassium food, more than 200 milligram per serving, which includes the fruits includes 1 medium banana, half of a papaya, half cup of prune juice, half cup of raisins, 1 medium mango, 1 small orange, half cup of cubed cantaloupe and 1 medium pears and avocado. Moving on to the vegetables, baked beans, refried beans, black beans, broccoli, raw carrots and greens, mushrooms, potatoes, tomatoes and vegetable soups. The other foods to be avoided are the bran products, chocolates, granola, milk all times, nuts and seeds, which includes peanut butter, and salt substitutes such as salt and salt-free broth and yogurt. And other important point to be taken care is to leach the vegetables. How to? The process of leaching will help pull potassium out of some of the high potassium vegetables. It is important to remember that leaching will not pull all of the potassium out of the vegetable. For potatoes, sweet potatoes, carrots, beets, winter squash and rutabagas, peel and place, here comes the leaching process. Peel and place the vegetable in cold water so that they don't get darkened. And the vegetables are sliced 1/8 inch thick and rinsed in warm water for few seconds, soaked for a minimum of 2 hours in warm water. Use 10 times the amount of water to the amount of vegetables. If soaking longer, change the water every 4 hours. Rinse under warm water again for a few seconds. Then cook the vegetables with 5 times the amount of water to the amount of vegetable. This process helps to leach the potassium and helps to maintain the electrolyte balance. To conclude, the symptoms of renal disease occur when 75% of function is lost, but considered chronic if only 90 to 95% loss of function is noted. The end stage renal disease is when dialysis become a compulsory requirement. Hemodialysis is done through fistula connecting artery and vein, whereas peritoneal is done by placing a catheter in the peritoneal cavity. Dietary salt, potassium, phosphorus and water intake should be restricted. So, when these things are managed, the dialysis could be maintained and the kidney function is also to be maintained. Hope the session is useful.